difficult. So I will now decide, you see, is that clear in the auditorium? That this will maybe be already a little bit too oblique to come in with the fast fix easily.
Yeah, it's well to see.
It's hard to see, right?
No, it's good to see.
Okay, but it's hard to see, so it's probably a little bit too oblique. So I'm going to switch to an inside-out device now. Ja, de meest gekeurde. Ja, die. Nee, de andere. Nee, die, ja. Mag ik kijken? De andere? Nee, dezelfde, ja. Die, ja, links, ja, die. Ja. Okay. So this is the inside-out device I'm generally using. There we go. So we're gonna put the needle in, maybe outside view, just to outside view. Doe even uw naam weg. So this is my my left hand positioning the device. Lynn will now introduce the needle. Okay. Yeah, push. Okay, stop. And I'm going to position it there. Excellent. Doorduwen en een draadje doorsteken natuurlijk. Ja. We're going to push it through the skin. Ja, push maar door. Ja, stop. Je zit er al. Stop. Draadje erdoor. And if possible, maybe I could position two sutures in the front. I mean, it all depends on how comfortable you are with the fixation and how easy the surgery goes. But generally, I put 1 to 2 sutures on if it's inside out, at the anterior horn. Excellent. Yes. You can pull now on the needle. Go. Pull maar. Trek maar. Perfect. Stop. Ja. Naaldje eruit. Nee. Nooit zo doen. Voilà. Anders beschadigt het de draad. Andere kant. Trekken. Ja. Perfect. So I'm gonna reposition my needle. Hoppakee. Houd eventjes even houden dat hier. I'm going to try to give you the perfect view, but as you can see, the corner is just around the corner. So yeah, I think it's going to be a little bit blind here. Anyway, yeah, go. Nee, stop. Waarom doe je dat nu?
Omdat het niet zo lang meer is.
Oké, go. Ja, nee, we moeten weerstand hebben.
Ja, ik heb weerstand.
Oké, perfect. Stop. Perfect. Excellent. So, nee, is goed. Okay. Outside view again. Lynn is picking up the threads. Yep. Go ahead, Lynn. So there we are. And now she's going to gently pull on both wires. And I'm going to switch again to the anterolateral view. There we go. To show you what we have done. This is the situation. Nice fit. And I'm going to just add maybe an extra one a little bit lower. That would be ideal, yeah. I'm going to switch back to the anteromedial view. Yeah. Excellent. So this one's going to be a little bit lower there. Wacht, nee. Even, ja, kom maar, toon uw topje. Zo, ja, ietsje terug. Oké. Okay. Excellent. Ja, wow. Ja. Okay. So you could use whatever fixation method you want with this Actifit implant. And in fact, surgery is ready at this point. We're going to just finish the suture. Okay.
Do you use sometimes out-in technique?
I'm not used to doing outside in except for the anterior horn, and with scaffolds, these anterior horn lesions are the most challenging lesions. So I would not urge the people in the auditorium to start with anterior horn lesions if they're planning to do their first scaffold. Just go for a regular posteromedial meniscus lesion. That would be, I think, the ideal indication to start with if you want to do your first scaffold. Again, the position here is a little bit blind. I'm going to try to make it as good as possible, but
Peter, if you deal only with a meniscus, do you sometimes use 70-degree scope from the beginning?
No. Trek een keer aan die draad. No, nee, andere kant. Ja, dat should. Gaat trouwens waarschijnlijk op. Stop. No, the 70-degree scope is I never use it, even not for PCLs. I don't tend to use the 70-degree scope. We're going to introduce the second suture. So it's somewhere in the back of the OR, the 70-degree scope.
Any question from the floor?
Oké. Hier stopletten, de andere kant. Ja. Excellent. Ja, we moeten eraan trekken.
What type of Johan Belmans asked you, Peter, what type of suture do you use?
This is Ethibond 2.0. So this is a situation, if I may be a little bit critical, this suture should be a little bit more lower, but I mean, this is a situation. You see, I pull it, it's a snug fit, but maybe the second one could be a couple of millimeters here. Ideally, it would be here, but we are already right in the anterior part of the meniscus, so this is the most challenging area to do the sutures. Lynn is now going to gently pull on these. We won't make the actual suture, but I want to show you the stability of the implant now. We're going to palpate. And you see, I'm really now pushing it in here and here. I'm pulling on it. And this is pretty stable. So this is it.
Just one question more, Peter. Do you use sometimes suture on the inferior surface of the implant?
No, and not here. In Gent we did now, I think, around 50 implants. We never sutured the inferior aspect of the scaffold. I mean, if you're used to it, doing it, I think you can do it, but I don't think it's necessary. But if you feel more comfortable with it, it's for sure possible. If, for example, the scaffold would be a little bit too big here in the anterior part, you can easily work your way into the joint with your classic basket and reduce size if necessary. But I think this is a nice aspect of the scaffold, and again, this should be a good result.
We agree with you, Peter.
Thank you.
The patient will go well.
Yeah.
Thank you very much.
Bye-bye.